Mechanical ventilation is a respiratory therapy that is becoming increasingly popular around the world. When applied appropriately, mechanical ventilation is a very powerful and effective means of saving lives, a lot of lives, because it maintains vital breathing functions in an artificial manner. However, if applied inappropriately, mechanical ventilation may be equally powerful and effective in harming patients. Mechanical ventilation might be the most challenging of all clinical therapies, not only because the therapy itself is complicated, but because the therapeutic tool, the ventilator system, is complicated as well. This is a fact which is not often recognized. The outcome of mechanical ventilation depends to a great extent on the specialist knowledge of the clinicians in charge. It is generally the case that the more the clinicians know, the better the outcome. What to learn? This learning unit is one of the most critical in this education program. After studying the material in it, you should be able to explain what pressure, pressure gradient, volume, and flow mean, what respiration really means, how lungs are ventilated naturally, how lungs are ventilated artificially or mechanically. Basic elements. Mechanical ventilation is closely related to and is dependent on pneumatics, which is a branch of physics. So if you want to know about mechanical ventilation better, this means not only what to do and how to do it, but also why things are as they are or will be. You must thoroughly understand the basic terms and principles of pressure, pressure gradient, volume, gas flow, resistance, compliance, time constant. Pressure. Pressure is a force against resistance or a force applied uniformly over a unit area of surface. Gas pressure can be expressed in various units. The most commonly used units in mechanical ventilation include bar, millibar, centimeter of water, kilopascal, hectopascal, and pound per square inch. Pressure gradient. Pressure gradient refers to the difference between the pressure at area A and the pressure at area B. If both areas are connected with a tube, the pressure gradient drives the air or gas to move from the high pressure area to the low pressure area. The gas movement is flow. Gas volume, V. Gas volume is a measure of the space occupied by a quantity of gas at a given pressure. Tidal volume and minute volume are two typical examples of gas volume. Volume is expressed in liters or milliliters. Gas is compressible, therefore under various pressures, the volume of a given quantity of gas varies. Therefore, a vast amount of gas can be compressed into a small gas cylinder. Gas flow. Gas flow refers to the movement of gas volume over time. Gas flow has two essential properties: direction of flow and rate of flow. Flow direction is determined by the pressure gradient only, while flow rate is determined by both the pressure gradient and the resistance encountered. Inspiratory flow refers to the gas flow towards the patient, usually expressed in positive values. Expiratory flow refers to the gas flow from the patient, usually expressed in negative values. The rate of gas flow is usually expressed in liter per minute or milliliter per second. 1 liter per minute is equal to 16.7 milliliters per second. At a low flow rate, gas tends to move smoothly. The resulting pattern is called laminar flow. At a high flow rate, gas tends to move unevenly. The resulting pattern is called turbulent flow. Resistance. Resistance is defined as a force that tends to oppose or retard gas movement. Resistance is flow dependent. Whenever a gas moves through a tube, a given resistance is generated. Resistance is usually expressed in millibars per liter per minute. The level of resistance is determined by 3 factors. The first factor is flow rate. The higher the flow rate, the greater the resistance, and vice versa. If the flow rate drops to zero, resistance disappears. The second factor is the physical properties of the tube, including its length, internal diameter, inner surface, curvature, and so on. The third factor is the physical properties of the passing gas, including its density and viscosity. Heliox is a gas mixture of helium and oxygen. It has a lower density than air. Passing through a narrowed airway, heliox generates less resistance than air, resulting in a higher gas flow. This fact forms the foundation of heliox therapy. The relationship between pressure gradient, flow, and resistance is described by Ohm's law. Flow equals to pressure gradient divided by resistance. So flow increases when the pressure gradient increases and/or resistance decreases. Compliance. A balloon and human lungs have one thing in common. Both are elastic, hollow, and gas-tight structures. Their volumes change at different levels of internal pressures. Compliance is a measure to express the pressure-volume relationship of such structures. A simple physical model can help our understanding. Here we have two balloons made of the same elastic material. The wall of one balloon is slightly thicker than that of the other. Using a T-piece equipped with a valve, we connect the two balloons to a source of high-pressure gas. In this arrangement, the internal pressure of the two balloons remains identical at all times. Now we gradually open the valve, causing gas to flow into both balloons and the internal pressure to increase. As a consequence, both balloons begin to expand. Unsurprisingly, the balloon with the thin wall expands faster than that with the thick wall. If we measure the internal pressure and balloon volume simultaneously and then plot the readings on a graph, we get two different pressure-volume curves. These two curves have different angles to the horizontal. These angles show the different levels of compliance of the two balloons. In principle, compliance is a static property and should be measured in conditions of zero flow. Compliance is expressed in milliliters per centimeter of water or liters per centimeter of water. Time constant. Flow is defined as change of volume over time. Keep in mind that it takes time to complete a course of volume change, such as in the process by which lungs are inflated or deflated. If the time available for lung inspiration or inflation is shorter than required, the realized tidal volume decreases. If the time available for lung exhalation or deflation is shorter than required, a part of the gas volume that should be expired is trapped in the lungs. This results in higher alveolar pressure at the end of expiration than would otherwise be the case. This phenomenon is called auto-PEEP. The length of time required to complete a volume change varies, depending on clinical conditions. The question is there any possible way for us to know or estimate objectively and individually the required time to complete a course of volume change? Yes, the tool we use is the time constant. The time constant parameter is the product of the monitored compliance and resistance of a respiratory system. Therefore, the time constant increases when resistance and/or compliance increase. In a passive lung model, the volume change of inspiration or expiration is exponential. This means the change is maximal at beginning and then slows down. The time constant, RC, is expressed in second. However, it does not directly indicate the length of time required to complete a flow course. Instead, it must be factored. In theory, after one time constant, 1 times RC, 63% of the volume change is complete. After 2 time constants, 2 times RC, 86.5% is complete. After 3 time constants, 3 times RC, 95% is complete. After 4 time constants, 4 times RC, 98% is complete. And after 5 time constants, 5 times RC, 99% is complete. It is generally agreed that adequate inspiratory time should be at least 3 inspiratory time constants long, while adequate expiratory time at least 3 expiratory time constants long. Why is respiration necessary? An adequate and continuous supply of energy is vital for life. Energy is produced in all living cells through a biochemical process called metabolism. This is comparable to burning fuel in a stove. During the process, oxygen, O2, is consumed and carbon dioxide, CO2, produced. Respiration is the process of moving O2 towards and CO2 away from living cells. The process has 4 parts. 1. Lung ventilation. This means the replacement of stale gases in the lungs with fresh gases from the environment. 2. Gas diffusion at alveoli. This means moving O2 from the alveoli to the pulmonary capillaries and moving CO2 from the pulmonary capillaries to the alveoli. O2 diffusion is driven by the difference between the O2 partial pressure in the alveoli and that in the surrounding capillaries. The same principle is true for CO2 diffusion, but in opposite direction. 3. Blood circulation to transport O2 and CO2 between living cells and the lungs. 4. Gas diffusion at tissues. This time is the moving of O2 from tissue capillaries to supplied cells, and the moving of CO2 from cells to tissue capillaries. Again, gas diffusion is driven by the difference of O2 and CO2 partial pressures between the living cells and the supplying capillaries. Human respiration is so precisely regulated that the partial pressures of O2 and CO2 in arterial blood, PaO2 and PaCO2, are stabilized within a narrow normal range, even under a wide range of physiological conditions. The term respiratory failure describes that the respiratory function is so inadequate that PaO2 and/or PaCO2 can no longer be maintained within their normal physiological ranges. Anatomy of airway and lungs. Respiratory system refers to the organs serving for respiration. The lungs, airway, and chest wall are essential parts of a respiratory system. They are responsible for lung ventilation and gas diffusion at alveoli. Functionally, the airway-lung structure may be divided roughly into 3 parts. The first part is the upper airway, including the nose, nasal cavity, mouth, pharynx, larynx, and trachea. The second part is the low airway, including everything from the primary bronchi and bronchial tree to the small bronchioles. As the names imply, the upper and lower airways are gas passageways between the environment and the alveoli. The third part is the alveoli. These are miniature gas sacs, each with a thin wall coated with blood capillaries. A normal human being has millions of alveoli in the lungs, so that the gas-blood interface is huge. The special structure makes gas exchange particularly easy. A simple model to demonstrate lung ventilation. Explaining the complicated mechanism of lung ventilation in an easily understandable way is a challenge. A simple and intuitive physical model can help. A fireplace bellows can serve the purpose well. However, we must take 2 modifications to the normal design. First, the one-way valve for gas entry must be closed so that the nozzle becomes the one and only gas passageway. Second, a spring must be added between the 2 handles to mimic the elastic lung chest wall. The elastic recoil force brings the extended bellows back to its resting position whenever external force is removed. We will often use this model to visualize the pneumatic mechanism of various forms of lung ventilation. And with our specially adapted bellows model, we are prepared to go on. Natural lung ventilation. A. Inspiration. Natural and quiet inspiration begins with downward movement of the diaphragm, causing the alveolar pressure, PALV, to drop below the airway opening pressure, PAO, which is equal to atmosphere pressure. Following the gradient, the air is sucked into the lungs. With the inspiratory flow over time, the lungs are inflated and the alveolar pressure increases gradually. Finally, inspiratory flow stops when alveolar pressure, PALV, and airway opening pressure, PAO, becomes equal. Natural lung inflation results from contraction of inspiratory muscles, mainly the diaphragm. It is an active, energy-consuming process. The muscle work must be sufficient to overcome the airway resistance, the nozzle in the bellows model, as well as the elastic recoil force of the respiratory system, the spring in the bellows model. The respiratory muscular work is called work of breathing, WOB. The muscular work required for the inspiration of normal quiet breaths is as low as 3 to 5% of total body energy expenditure. However, this work can increase dramatically under abnormal conditions, such as asthma or acute respiratory distress syndrome, ARDS. B. Expiration. Natural and quiet expiration begins with relaxation of the diaphragm. The elastic recoil force of the lungs and chest wall brings the enlarged lungs back to their resting position, which is called residual functional capacity, or FRC. Natural and quiet expiration is passive, consuming no energy. In our bellows model, the spring, which was loaded during the inspiration, generates a positive internal pressure, pushing the gas out until the bellows is back to its original position. Artificial lung ventilation. Artificial lung ventilation can be achieved in 3 ways: intermittent positive pressure ventilation, or IPPV, intermittent negative pressure ventilation, or INPV, and high-frequency ventilation, or HFV. Most modern ventilators are based on IPPV. From now on, when talking about mechanical ventilation, we mean mechanical ventilation with IPPV. To keep our explanation simple, we assume that the ventilated patient is totally passive. A. Inspiration. When artificial inspiration begins, the ventilator system raises the airway opening pressure, PAO, from the pressure baseline to the peak pressure, generating a temporary gradient where the airway opening pressure is higher than the alveolar pressure. The gas is pushed into the lungs. With inspiratory flow over time, the lungs are inflated and the alveolar pressure, PALV, rises exponentially. At the end of the inspiration, both the airway opening pressure, PAO, and the alveolar pressure, PALV, are equal at peak pressure level. The inspiratory flow stops. B. Expiration. When artificial expiration begins, the ventilator system suddenly lowers the airway opening pressure, PAO, from the peak pressure level to the pressure baseline, generating a temporary gradient where airway opening pressure, PAO, is lower than the alveolar pressure, PALV. The elastic recoil force of the lung-chest wall pushes the gas out of the lungs. In our bellows model, the spring, which is loaded during the inspiration, represents the recoil force. With expiratory flow over time, the lungs are deflated and the alveolar pressure, PALV, drops exponentially. At the end of expiration, the alveolar pressure, PALV, and the airway opening pressure, PAO, are equal at the pressure baseline. The expiratory flow stops. Similarly to natural expiration, such an artificial expiration is passive, consuming no energy. Conclusion. To understand comprehensively how a ventilator system works, it is at least necessary to know well 7 physical terms and principles. The primary function of the respiratory system is to transport oxygen, O2, to, and carbon dioxide, CO2, away from living cells of the human body. Complete respiration has 4 sequenced steps. Lung ventilation is one of the 4. Lung ventilation is realized by intermittent changes, naturally or artificially, in gradient between airway opening pressure, PAO, and alveolar pressure, PALV. The pressure gradients may be generated with 3 driving forces. This means respiratory muscle contraction, a ventilator system, and elastic recoil force of lungs and chest wall.